Anyway, so the case I want to present, I call it the Great Save. Have Procter and speak for a couple of companies, nothing that influences what I say here. So this lady, CT, was 73 years old. She donated $15 million to Ochsner Institution, so she obviously could choose her doctors and pretty much get her way. She needed an ovarian tumor resected and had sudden onset of painful swelling in her left lower extremity. Her exam was consistent with iliofemoral thrombosis, and color flow Doppler demonstrated iliofemoral disease. When you look at the venogram, and this is in a prone position, so this is the left, not the right, you can see that she has occlusion just below the level of the common femoral vein. Here you see catheters placed across this occlusion. A rheolytic thrombectomy was performed, and this shows a video image of her post-thrombectomy venogram. Now, what you notice is that there is not a ton of residual thrombus, and that you have created a lumen with a device which is pretty much an assay for fresh thrombus. As you saw earlier in one of these cases, it wasn't fresh thrombus, so it didn't do a lot. So balloon dilatation is next, was performed. And then this patient was stacked up with 5 stents to create a lumen in this femoral vein. Now, at the request of her OB/GYN physician who had referred her to us for this iliofemoral DVT, they requested, with absolutely no evidence to support this, in a patient who could be anticoagulated, who was going to have a laparoscopic procedure, they pretty much said, want filter, and we said, filter's in. So we were pretty much told what to do here and placed an IVC filter. So it was deployed, as you see there, and it was a cordis optis, and the plan was to put this in, remove the ovarian tumor, and then do whatever was appropriate afterwards. You see post-deployment, renal veins are up here, it's above the iliac bifurcation, so all that looks pretty good. And that's the final position. Now, as the history continues, she was kept on dual antiplatelet therapy and warfarin for 2 weeks. Her ovarian mass was removed via laparoscopic surgery through a Lovenox window while we kept her on aspirin, but stopped her Plavix. And then the pathology came back benign ovarian cyst. So we scheduled her for filter retrieval in the next week. Within about 10 to 12 days, we were going to remove her filter because she no longer had need for a filter to be in place. Now, she had different plans because she now was a very well-to-do lady who, when her pathology results came back, she decided that that was time to throw a humongous party. And this party was, Audubon Place for doctors, half the hospital, all of her friends. So this took considerable planning. So it considerably delayed, and she pretty much chose when she wanted to come back to get her filter removed. So it was extended, but nevertheless, she came back, and we attempted to remove the filter with a 15-millimeter gooseneck snare. And here you can see collapsing the filter completely, pulling maybe 10, 15 pounds of pressure on this. And here you can see with a venogram performed that it's almost complete occlusion of the inferior vena cava. So this filter is not coming out. And this is, and they experience pain. You're sucking their adventitia, their vessel pretty tightly in, and these people hurt when you do this. So note that that's completely occluded. So we're stuck now. So we turned the filter loose and said, well, we've learned our lesson. Retrievable filters are not always retrieval. It would be easy to rupture the IVC if you keep persisting because she was hurting, and we're going to hurt her now, so it's time to turn it loose and let it go. But we could not disconnect this filter from this gooseneck snare. So we couldn't get it off. Now you note, now she's in a supine position now, and this is the left iliac system. And here's this gooseneck snare stuck on this Optese filter, and we couldn't get it to release. So what the heck's going on here? Now, we were unwilling to access this contralateral. We wanted a second pair of hands to help us to try to manipulate this and get it off. But we were unwilling to stick this. It would have probably been okay to put a stent through, a sheath through this stent on the contralateral, but we decided to put another stent on the ipsilateral side. And we fumbled and we fiddled and we spent an extended amount of time. This is 40 minutes, an hour, and we fumble around, and we could not get this to turn loose. And so it was still stuck, and you see we've pulled and tugged and etc. So we decided to leave the snare in the IVC with all the other endotrash, filters, stents, etc., cut it off at the common femoral vein. I'm just kidding. We didn't do that. So what we did was we got IJ access. It's a suggestion of, we called for help. We cried uncle. We called the radiologist. And one of our colleagues, Dan Devon, got Reuter's deflecting wire, and he came from IJ, and he fiddled with it from above. We fiddled with it from, and there was like 4 of us in there doing this. And, of course, we had plenty of time. Like Metzger says, we're not hurting anything, so we're not going to rip the IVC out trying to pull the snare out, but we keep trying to work through this and figure it out. So actually it came loose on its own, probably would be my guess, because it just finally came loose. And so we took a venogram to make sure we didn't rip and tear the inferior vena cava, and this is our final venogram. Everything was well and no problem. So, what happened is 6 weeks too long in some people. Well, people endothelialize at different rates. People, younger people, in my experience, this is anecdotal, tend to, these things become permanently attached to the IVC. Older people with maybe less active immune systems, in my experience, octogenarians, etc., it seems to me I have a much higher chance of pulling these out. But so nevertheless, why could we not disentangle it? But I'll tell you, we contaminated one snare before we got the one that was sterile and used it and hung it. And so we compared the two on the table and took a picture of that after the procedure. Now, if you remember the picture where we were tugging extremely hard and you saw the tip of this catheter evert and over evert over the filter, what happened is that radio-opaque band marker on that retrieval sheath that we had the gooseneck snare through had fractured that tip off and locked this gooseneck snare right there on the tip of that wire. Now, in retrospect, go back and look at this. You see this little piece here? So this is the little piece that came off of here. It fractured off the end. It doesn't look torn. I mean, this is the little, radio-opaque piece of the end of that, and it locked that. You see how it's still holding it together on there? So anyway, that's what happened, and that's how we got out of this. So the moral to this story is take nothing for granted. All equipment and techniques have limitations. Don't be afraid to ask for help. Learn from your experiences every day, every case, and when you have bad experiences, such as I have and such as Metzger has, you should share those experiences with others so that hopefully they can learn from them. So if you ever cross this path in your future and you have a snare that you've pulled very hard on some object that you were fishing for in a human and it's stuck, think about fracturing the tip of your retrieval device and locking the snare on whatever it is you're trying to capture. So, thank you.
All right, so Steve, for the sake of time, we're going to have you go right ahead into your next talk.
Okay, so I'm going to talk about peripheral venous insufficiency. So I proctor and speak. A few minutes ago, I was walking down the hall, took all these pens from the vendors, but I don't think any of that conflicts me for what I'm going to say. Now, venous thromboembolism occurs in 1 per 1,000 per year in the U.S., of which 2/3 develop DVT alone. 1/3 of those manifest PE with that. It's responsible for 250,000 hospital admits per year, of which 30% die within a month and 30% have recurrent symptoms. And if you have a symptomatic PE, you have a much, much higher incidence of mortality with this disease. Now, if you count both the incident and recurrent VTEs, it's roughly 1 million per year in the U.S., an incidence which has not changed in the last 25 years. And survival after venous thromboembolism is much worse than age and gender match controls. It comes with a host of consequences, such as recurrent venous thromboembolism, post-thrombotic syndrome, CTEP, and then the increased mortality that I told you about. Now, in this New England Journal article published by Pango in 2004, he followed 355 patients with venous thromboembolism for 8 years, and he found a 30% at that 8-year time frame, a 30% incidence of recurrence, a 30% incidence of post-thrombotic syndrome, and a 30% mortality. If you take nothing away from this lecture for the next 15 slides till I finish, please take away that any question you're ever asked about venous thromboembolism, the answer is 30%, because that's the only number I've told you in the last 5 slides. Now, the problem with evidence-based guidelines from ESC, SIR, ACCP, until all of these people have, societies have updated them recently, is they addressed only the acute and chronic medical management therapies for venous thromboembolism. And they did nothing to direct people such as you who are interventionalists on the aggressive, more invasive therapy for this disease. Now, recognizing that void in the guidelines, Michael Jaffe and ACCHA published guidelines to direct us in treatment of this disease in March of 2011. And in those guidelines, it gave for catheter-directed thrombolysis or pharmacomechanical catheter-directed thrombolysis for this disease, it gave a Class 1 indication for limb-threatening or circulatory compromise, a Class 1 indication to put that patient in an institution that had expertise in this disease if they present to one that doesn't offer it, a Class 2A indication for symptomatic deterioration despite anticoagulation, a 2A indication as a first-line therapy to prevent post-thrombotic syndrome, which is one of the only things that this therapy does reliably, is it decreases incidence of post-thrombotic syndrome. It gave a contraindication for this, for systemic fibrinolysis for this disease, and it gave a contraindication if you had more chronic disease, although some people would challenge that now, greater than 3 weeks of age. So, traditional anatomic division for this disease is proximal and distal DVT at the level of the calf. And that's logical because of the increased risk of pulmonary embolism with proximal DVT. But for an interventionalist who wants to practice interventional therapy on this, it is woefully inadequate. That division instead should be made at the level of the common femoral vein. And the reason for that is that obstruction at the level of the common femoral vein or above obstructs not only the God-given pathway for drainage of the lower extremity, but all collateral pathways capable of draining the lower extremity. This is termed the iliofemoral DVT, and it encompasses roughly 25% of lower extremity DVT. They have worse symptoms, they have increased incidence of late clinical sequelae, and I will not regurgitate those in the interest of time. So, the interventional anatomic division, distal to that, so this time right here, Mike, is from my first talk, not my second one. So when that comes red, don't cut me off. Okay. Now, the division distal to that, distal to the common femoral vein, is one that you might more consider the more conservative therapy or medical management of this, and that might be more appropriate than an interventional therapy for this disease. If you're going to play in the venous space, you have to know this syndrome, Thurner Syndrome. It's been mentioned in the several times today. May-Thurner or Cockett syndrome occurs when you have obstruction of the left common iliac vein between the right common iliac artery and the spine. It was originally described by May and Thurner in 1957 in a quarter cadaver dissections, and there was also a radiology CT study which published a similar incidence in 2004 in a quarter of CT studies. Now, this is the classic pre-stenotic dilatation that you get with May-Thurner syndrome. And here you see after balloon angioplasty, there you have to see after a stent. Magnetic resonance venogram, CT venograms, in my experience in my institution, are also terribly inadequate for reliably diagnosing this disease unless you know the subtleties of diagnosing it instead of looking at your radiology reports and you look at them yourself. There are only two modalities I know that reliably can detect May-Thurner syndrome. And one of those is what's called an aortocablegram, where you place a catheter in the aorta and the vena cava, the iliac vein at the simultaneous injections, and you can see there where there's obstruction of the left common iliac vein. The only other modality I know that will diagnose this in 100% of cases, and these two modalities are 100% accurate, is IVUS. If you look at this image, you see the aorta on top, you see the inferior vena cava right here, and you see as we pull this catheter down the IVC and above, look at the aorta split. I'll stop it. Right common iliac artery, left common iliac artery. This catheter right here, as I drag this, you can see, boom, there's May-Thurner or Cockett, where your left common iliac artery compresses the left common iliac vein between itself and the spine. I'll let that play on through quickly, and then you'll notice the pre-stenotic dilatation that I told you. So that's another tip-off for you if you see a pre-stenotic dilatation or a vein that's very big in your common iliac vein. So, and just here it shows it in steel panels. Now, the way to treat this is with stenting. And stenting, you have to make certain on your AC gram, if you take that afterwards, make certain that this vein stent crosses that right common iliac artery. Otherwise, you do not effectively treat this with your endovascular treatment. Now, my last few slides, I want to quickly tell you about vein lysis for this disease. If you do this, it will encompass absolutely all of these modalities, especially the last one. You'll include balloon angioplasty. These are not cheap procedures. You typically do mechanical thrombectomy, catheter-directed thrombolysis, although the case I presented to you earlier, there was fresh, acute, and not much thrombus, and all we did was mechanical, no thrombolysis. But typically in these vein cases, you do thrombolysis. And you have to stent. Veins love stents. Joints and veins love stents. Veins love stents. It's a different bird than an artery. Neointimal proliferation is slower, etc. It's just different, and it takes you lots of time. You choose your choice of anticoagulant. If you have hit or hits, obviously you have to choose appropriate drugs, but mine favorite is unfractionated heparin because it's the cheapest. UK is no longer on the market. Streptokinase was, I think they used for dinosaur thrombolysis, but TPA is the typical drug, 0.01 mg per kg per hour. That roughly calculates to a total of 1 milligram per hour in most humans, such that you would give a 20 milligram vial over your 1 day's period before you come back and do your relook. These cases take 48, 72 hours. You're lucky if you get them done in 24. Yes, some of the newer modalities, et cetera, can shorten that time frame. The data we have to support this are two. One's the Torpedo Trial. It was a randomized trial of peripheral intervention plus anticoagulation versus anticoagulation alone for people who had symptomatic lower extremity DVT, and it looked at the 30-month post-thrombotic syndrome and mortality rates. If you look at the post-thrombotic syndrome reduction, there's a significant reduction when catheter-directed thrombolysis is used or an intervention for treatment of this disease compared to anticoagulation alone. And there is absolutely no mortality benefit, although there is a trend, as you see in the interventional group. The other data we have is from the Cavent trial. This was a randomized trial in 209 patients with a first-time acute iliofemoral DVT randomized to conventional medical therapy versus medical therapy plus catheter-directed thrombolysis. The 24-month post-thrombotic syndrome, as assessed by Villalta score, and iliofemoral patency was examined at 6 months. And in the results of that, there was a significant reduction in favor of catheter-directed thrombolysis for post-thrombotic syndrome reduction. There was a significant benefit for iliofemoral patency in that group who was treated with catheter-directed thrombolysis. But what's interesting in that is regardless of how you regained iliofemoral patency, whether it was the catheter-directed thrombolysis group or the conventional therapy group, those patients that regained iliofemoral patency after DVT had a highly statistically significant reduction in post-thrombotic syndrome. So patent veins work to reduce post-thrombotic syndrome. So in conclusion, iliofemoral patency, femoral veins, increases the morbidity and mortality in these patients. Aggressive interventional therapy reduces the long-term sequelae, and I think the evolution of treatment of this disease has evolved into catheter-directed and endovascular therapy, and I thank you.